Good evening, everyone. So on behalf of the Board of Directors, Senior Management Team, and staff of Family Guardian Insurance Company Limited, Bahama Health, I would like to welcome you to another segment of our Doc Talk series. This evening, we have a lively back-to-school panel in store for you. It is said that children are a gift from God, and we want what's best for them and to keep them safe. In this vein, the goal is that at the end of the presentations, you will have the latest information on how to get them prepared to go back into the school environment. We hope that you ask lots of questions and enjoy this Doc Talk segment. Thank you. Thank you so much. So at this point, please welcome Aliyah Adderley, who will introduce our speakers.
Good evening, everyone. Dr. Sean Knowles, Dr. Merritt, obtained her bachelor's degree in biology from Georgia State University, then pursued medical studies at the University of the West Indies. After successful completion of medical school in 2011, she interned at Princess Margaret Hospital, then undertook pediatric specialization at the University of the West Indies, which she successfully completed in July 2018. She enjoys teaching and is an associate lecturer at the University of the West Indies. She currently works as a consultant at Princess Margaret Hospital in the pediatric department and also at Precious Posterity Pediatric Center. In her spare time, she enjoys spending time with her family and traveling. Please welcome Dr. Knowles Merritt.
Good afternoon. Thank you for your introduction. I will share my screen. Okay, can you see the slides, my slides?
Yes, we can.
Okay, and you can hear me well. Okay, I'll begin. Thank you. It's a pleasure to be here and share this information with you and your parents today. So briefly, we'll just be talking about viral upper respiratory tract infections, or basically the common cold, which is very common in our toddlers and preschool aged children. And then we'll briefly look at how important nutrition is and how it ties in with these infections. So we will define what our upper respiratory tract infections are, look at some common viruses, how it's transmitted, how the role our immune system plays, common symptoms, what parents can do at home, and then we'll briefly touch on nutrition and how important nutrition is. So the respiratory tract is divided into basically the upper and the lower, but for the purpose of this talk today, we will just be focusing on the upper respiratory tract, the nose, the sinuses, the throat, the oral cavity, okay? So we know that viral upper respiratory tract infections are acute infections. They are mainly caused by viruses. However, they're usually mild, and essentially viruses include rhinovirus, which is one of the most common cause for the common cold. We have respiratory syncytial virus, parainfluenza virus, and adenovirus. The point I would like to make with this slide, however, though, is that I want you to remember that there are many serotypes associated with these viruses. So it's just not one rhinovirus that your child may be exposed to. These infections can occur at any time of the year, but it's most popular during the fall now and the winter months. Okay, and you would find that the rhinoviruses are more common during the fall season, and the respiratory syncytial virus during the winter months. So parents always ask when they are in school. So essentially, are transmitted is through contamination. So they may touch an object, touch their nose, rub their eyes, and infect themselves that way. Or an adult or child may have the virus, would cough or sneeze, and they would inhale those air droplets. The risk increases if they are in close proximity to the individual who or child who may be infected, and the amount of time they spend with that person. Incubation period now is also something that we look at. So it's the time of exposure, the time they were exposed to the virus, and also to the beginning of symptoms. So they may have come in contact with the virus this incubation period can occur between 24 to 72 hours or 1 to 3 days. Okay, so they may have come in contact with the virus the day before, and then the following day they can begin to exhibit symptoms. What the immune system does. So the virus now deposits itself on the mucous membrane of the nose, the eyes, now enters the body, and the body now, or the immune system now recognizes this virus as being foreign. This should not be here. Okay, this is not normal. So now the immune system, there's an inflammatory response that occurs. There's influx of cells that fight infection, particularly the neutrophils. And then you would have the onset of symptoms. So parents always ask, why does my child always get these runny nose, cough, these viral infections? Children younger than 6 years old can have an average of 6 to 8 viral infections per year. Okay, so it's very common. And then, it's kind of difficult to teach kids, don't put your hand in your mouth or your eyes, or don't touch your nose. That's very, very difficult at this particular age. Young children in daycare tend to have more viral infections than children cared for at home. However, the other side to this, children who were mainly cared for at home and were not exposed to these viral infections, when they are now introduced into the school environment, they tend to have more viral infections than those who attended daycare in their infancy years or infancy time. Remember, I spoke about serotypes. So your child being exposed to, for example, rhinovirus type 1 does not prevent against a subsequent infection against rhinovirus type 2 because there are so many serotypes. Okay. However, subsequent infection with the same serotype is generally milder and of a shorter duration. Common symptoms: your child generally feels unwell, they're not as active and running around and talkative as they normally are. They may have, on day 1, you may begin to notice a fever. On day 2 and 3, fever may persist, along now with some nasal congestion, runny nose, sneezing, decreased appetite, sore throat. Okay, so those are the common symptoms. Complications can occur after having these viral infections in the form of ear infection, sinusitis. If your child is known to be asthmatic, it can precipitate an asthma exacerbation. So if these things occur, definitely you would need to seek your pediatrician as soon as possible. Education is key with the management. Parents, there is no need for antiviral or antibiotic therapy with the common cold or for the majority of these upper respiratory tract infections. Like I mentioned earlier, they usually resolve on its own. There is viral therapy for the influenza virus, but again, for the most part, most kids usually handle that well. They usually, the symptoms usually resolve on its own as well, but you would need to see your pediatrician early if it is in fact influenza. If you would want, if they think you should have antiviral therapy. Symptoms, like I mentioned, usually peak or are worse during day 2 into day 3, and the symptoms would gradually resolve over 10 to 14 days. The cough may linger, but it should be getting better and not worse. If it is lingering, please see your pediatrician. What can you do at home? Supportive care is what we recommend. Keep your child hydrated. Let them drink lots of warm liquids. Saline drops or the saline spray that help with the congestion and the runny nose. Acetaminophen. So parents, acetaminophen can be given, which is essentially children's Tylenol, Panadol, Cetamol, okay? And you can give that safely for fever. Ibuprofen, which is also children's Motrin or Advil, really should not be given in children under 6 months old. And usually if they are not eating, you would not want to use ibuprofen on an empty, give them ibuprofen on an empty stomach. Okay, avoid over-the-counter cough suppressants. You do not want to suppress the cough, especially in children under 6 years old. The World Health Organization, I read an article which actually showed that honey, if you give them in a little bit of warm liquid, can. But please remember, you should not give honey to children under 1 year old. What can you also other mitigation strategies? Keep your child home if they have a fever and they are not well, because you don't want them to now infect other children. Teach your school-age children to wash their hands frequently, to cough and sneeze in a tissue or the crook of their elbow. This can be, of course, you won't be able to do this with your toddlers, so you would have to look and see what mitigation strategies your daycare or nursery may have. And they did find that the alcohol based hand sanitizers help to control illnesses. Ensure that you continue so that they can ensure that your nutrition play a role. So we know that a healthy diet boosts your immune system or boosts immunity, okay? a well-balanced diet is very important with your proteins, your fat, your carbohydrates, vitamins, and minerals. That's a whole lecture in itself, but I would like to focus mainly on the sugar intake of kids, which I think is a major problem now. You should avoid foods and beverages with added sugars. I tell my parents, kids less than 2 years old, don't give them any juice. Okay? Greater than 2 years old, really and truly, if you can continue to avoid these sugary beverages, that would be great. But keep in mind, the maximum amount of sugar they should have in a day really is about 6 teaspoons. If you think about it, and that's not a lot, which is 25 grams. I would like to plug in here too, parents, get used to reading the labels on when you go to the store, turn the package around and get used to reading the labels to see how much sugar and how much added sugars are in what you're giving your children. Encourage them to consume whole fruit rather than fruit juice, okay? And beverages really should consist of water and milk. Whole milk if they're less than 2, and greater than 2, you can use 1% or the 2%. Some kids are allergic to whole milk or the cow milk. They do soy or oats, but you still talk to your pediatrician about using those because some of those don't have the amount of calcium and vitamin D that you would find in the whole milk, but they are still can be a substitute. Tips to encourage fruits and vegetable consumption. Provide hands-on experience. Take your kids grocery shopping. Let them pick out the fruit. If you garden, I don't know how many people do that, but let them help you with that. Involve them in the selection of fruits. Cut your fruits and vegetables into shapes that they can dip, maybe in a little bit of peanut butter for kids who like peanut butter. Be a role model. Let them see you eating fruits and vegetables. Add your vegetables to the pasta, sandwiches, pizza, and provide repeated exposure. Tell them this will help you grow big and strong. Kids like to hear things like that. Good snacks include your fresh fruit, your whole grain, peanut butter, sandwiches, yogurt, raw vegetables. So a lot of parents always ask me as well, do I need to give my kids multivitamins? Will that prevent them from getting the cold? No, it will not prevent them from getting exposure to these cold viruses because our kids don't live in a bubble. They have to go to school, they have to go to church, they have to go to the store with you. So as long as your child is healthy, they have a well-balanced diet, they're eating their fruits, their vegetables, routine supplementation is not mandatory. Standard pediatric multivitamins, however, does not pose a risk, but it should not be used as a substitute for a healthy diet. Vitamins that appeal to children, keep away from them. I had a parent who told me that she gave her child, she had gummy vitamins, and I hope that Dr. Davo will comment on these gummy vitamins if there's something that should be recommended. But the child ate practically half the bottle as if it was candy. So keep those away from children. There are some recommendations when we have to use multivitamins. However, if your child is not gaining weight appropriately or if they have certain chronic diseases. Parents, please do not send your kids to school with 2 boxes of juice, 2 bags of chips, and 2 packs of cookies. That is not a healthy lunch. Sugar, coloring dyes, and preservatives. That does nothing to boost your child's immune system, okay? So we have to be creative. This is an example of a lunch box, and you see the different compartments. You see half of the lunch box is filled with fruits and vegetables. The other half, you have like a nice little sandwich, you have some yogurt, but you also have a fun, I guess what a kid would call a fun snack in the form of a muffin. You would just have to make sure it's not filled with too much, no preservatives and sugar. Okay? So a healthy diet equals a healthy child, which will equal a healthy adult in the future. So while nutrition may not prevent your child from being exposed to a cold, it can give your child a healthy immune system, boost their immune system so that their body will be able to um, um, handle these viruses and possibly have a short duration of illness. Okay, so that's the end of my presentation. My time is up.
Well, good evening, everyone. I'm Nurse Monroe, clinical nurse reviewer here at Bahama Health. And first off, we would like to thank you so much, Dr. Knowles, for that very informative presentation. We will have a question and answer segment for both of our presenters later on in this evening's segment. At this time, it gives me great pleasure to introduce our second speaker. Dr. Christine Darville grew up in Nassau, Bahamas, where she attended Queens College from elementary to high school. As a child, her dental visits were limited to emergencies, which was very typical and still is today for many children. After having a rocky start with her first dentist, she eventually had a dental visit that left a lasting positive impression on her. Consequently, this motivated her to pursue a career in pediatric dentistry. After graduating with her dental degree at Meharry Medical College, Dr. Darville went on to complete her pediatric dentistry residency in a hospital-based program at Metro Health Medical Center in Cleveland, Ohio. During this, she developed a love for teaching. Therefore, she decided to remain on staff, providing patient care as an attending dentist, as well as to teach dental residents. In 2012, she returned to her alma mater as a chairman and associate professor in the Department of Pediatric Dentistry. Realizing the importance of giving back to her country, she moved back to Nassau in 2013. In 2017, she opened up My First Dentist, a well-known pediatric dentistry practice that provides quality care in a kid-friendly environment, which allays children's dental fares. Additionally, her most recent accomplishment was the opening of Premier Dental Group with Dr. Barry Russell, a multi-specialty group catering to the entire family. Ladies and gentlemen, please join us in welcoming Dr. Christine Darville.
Can you guys hear me?
Yes, we can hear you.
Okay. I have my husband on the side of me, and I actually supposed to hyphenate my name like Dr. Knowles, because I'm now Dr. Kristen Darville Gardner, but I'm not used to presenting with that name since we just got married. And he's also here to help with the technology aspect of this because I'm not like tech savvy. So if you see this person on the side, that's my tech support. But thank you guys for having me. I love that presentation that preceded mine because a lot of things are going to be repetitive, which should just solidify where we're coming from as pediatricians and pediatric dentists. But one of the things I want to start off with, you guys did a wonderful introduction, so I don't need to say anything about myself, but just really the importance of the difference between a pediatric dentist and a general dentist. So with being a pediatric dentist, we definitely look into all aspects of your child, and you go through extra years of training to do things that relate to children, whether that's nutrition, their overall health, liaising with pediatricians on the latest evidence-based studies and whatnot. And also we're trained to deal with special needs patients and those patients that are medically compromised. So I definitely speak to pediatricians all the time just about how to take care of these little ones, even though they're just coming to the dentist. Because a lot of times, especially in the Bahamas, people are like, well, you just a dentist, like, why you want to know like who the pediatrician is and all that kind of stuff. But basically it's your child's overall health, which obviously includes their mouths. But basically I want to start with, let me see if this goes by next. This is our team, this is our office, and I put this up here so that you can kind of see that our whole staff is basically trained to deal with being friendly towards kids. The office is designed to make sure that kids come in and they know that it's for them and it's kids friendly. And all of that makes a difference when your child is going to the dentist, whether they start at 1 or they come a little bit later, because their first impression, being first dentist visit or whatever, is what usually sticks with you throughout the rest of your life. Hence the reason, again, why we have a lot of Bahamians who don't like the dentist, because they were definitely traumatized, as I was at some point. So the first thing I want to start with is, when should you send your child to the dentist? First visit by first birthday is the rule of thumb. Or if your child doesn't have any teeth by first birthday, which happens sometimes, you would wait about 6 months after the first tooth comes in. So a lot of times I have parents who come in and they're like, my child is 1 and they don't have any teeth. Or, you know, the child might come in at like about 4 months and have teeth. So we kind of use that general rule of thumb that by age 1, that's a typical first birthday. Why? Why would we want to do that? Because parents already develop horrible habits past 1. So we want to try to make sure by the time they have a full set of teeth, which is 20 baby teeth, that they're already doing all of the things that need to be done to prevent cavities, because we do not like filling, drilling, pulling teeth on these little ones. It's very hard. It's rough on the parents. It's rough on the kids. It's rough on me. So we like to try to do prevention. And the way that we do that is that we have this visit, that's 1, and we talk to the parents about what kinds of habits are they doing. Are they putting the child to sleep with a bottle? Are they putting rice cereal in the bottle to make sure this child sleeps through the night? Are they doing Milo, before bed because the child wants something hot on their stomach? It's just all kinds of stuff that people do that lead to decay, and things that people think that don't lead to decay would be falling asleep on the breast or rolling over at night and just putting the breast in the mouth and breast milk is on their teeth. Breast milk by itself doesn't cause decay, but breast milk, along with the fact that they're eating other things, now becomes a pool for bacteria. So you have a lot of parents that come in and they're like, well, I only breastfed and I didn't do the bottle thing, but the kids have decay on all the front teeth by 1.5, 2 years old. So that is the significance. We talk about habits, we talk about diet, and we just talk about like, what are you doing to take care of your child's teeth? And this usually happens before preschool age. So sometimes you'll call around and you'll get conflicting information, but the recommendation by the American Academy of Pediatric Dentistry and Pediatrics is first visit by first birthday. And so when do we recommend that you schedule these visits? Obviously, it's better before the school year starts, hence the reason why the summer is so crazy, but school is already starting. So we tend to make sure that the kids that are really, really young are seen in the morning before they go to daycare. Usually that's when they're most alert, they're not cranky, and we can kind of get those younger kids out of the way. The school age kids, we try to see them in the afternoon. So those appointments are booked specifically to accommodate those kids who have to go and attend school and get homework and all that kind of stuff. And then our special needs population, whether or not your child may be on the spectrum, or if your child has a special syndrome that I have to take extra time for, those are the visits that we do at the end of the day. A lot of times parents are skeptical. They don't want to be in a busy waiting area with a lot of people. So they want to come in when I can take unlimited time. So that means I have to go way past 5 o'clock, just so that your child feels comfortable or the patients that I need. That's why. So a lot of people don't realize when you call a pediatric office, we have certain rules. They're not rules that are just in place because we want to make them like that. They're specifically catered to the population, the pediatric population that we're seeing. So this is a cute little girl. She's so grown up by now, and a cutie pie. They both had their first visit by their first birthday. Sometimes it grows super duper well. Sometimes they will not sit in the chair like this little one. And this little one, she already had multiple visits. So by 3 years old, she's just like ready to go. She's already having a good time. And a lot of parents ask me, how do you get in? I don't want to bring them because they cry. They don't let me look. And I'm like, we're trained for this. This is what we do. And so this is a knee to knee exam. This is a typical way that a pediatric dentist would look in your child's mouth that's that young, which is the mom holding the child and comforting them and holding them. And then they're laying in my lap as I clean their teeth. And the first visit consists of an exam, a true cleaning, and a fluoride treatment, which we recommend at their first dental visit. So why does pediatric dental care matter? We see so many kids with so many decayed teeth. It's so crazy the amount of decay that I see on a regular basis. Like I could probably count on one day how many kids don't have cavities. It's way more children with decay than not. But what a lot of parents think is typical, the teeth are going to fall out, their baby teeth are going to fall out. But the fact of the matter is the teeth don't fall out until about 10 to 12 for the back teeth. And then the front teeth between 5 and 8 years old. At this point, they've already started school. So you already have issues that can lead to pain, discomfort, affect their ability to focus in school, whether or not they're picking at the cavity or they're having pain. They have to go to the nurse's office. Sometimes there's swelling involved. As well as I have had children as young as 3 and 4 years old being very conscious of the way that their front teeth look, or they've been teased at school and this, that, and the other. So a good way to make sure that you kind of nip that in the bud is to have your child start dental visits early and to not neglect baby teeth and brush it off as they're just baby teeth. So this is a sample of a child who came in. We didn't restore all of the teeth, but as you can see, all of the top teeth are decayed. The bottom teeth are decayed as well. And so basically these visits can be multiple visits. It can be very tiring and burn out or whatever in terms of the child having to come back multiple times. And then also the things that you have to consider is how will the child sit for this when this is completely a preventable disease. This is another child that came in, and her chief complaint at 4 years old is, "Mommy, I have teeth that look like a vampire." So we did our best to save the teeth because the mother also didn't want the child to go to school with a gummy smile. But either way, this is also preventable. And this child was on the bottle until about 4 years old. This is a horrible case. This is called severe early childhood caries. Every single tooth 4 years old is decayed. Every single tooth just about needs to be extracted. And the teeth, I always tell parents, are not like plants. You can't just pull them out and expect a tooth to grow back. It still has to go through the phase of when it's actually supposed to come in. So obviously this child presented with a lot of pain. And not only that, it just looks like neglect. This is pure dental neglect. Other things that you see is dental abscesses, which is pus, and that is coming from the tooth that's either been traumatized or decay can lead to the tooth abscessing. And once this happens, the tooth also needs to be extracted. And then this is a child with a facial cellulitis, and this is the point where it kind of gets dangerous. At this point, I usually have to refer the kids to their pediatrician, either for an IM injection of antibiotics, or sometimes they have to do IV antibiotics, which again is preventable. It also causes a lot of expense that's unnecessary. And then the child doesn't want to go to the pediatrician to get a shot of antibiotics or IV antibiotics, and the nurses have to find a vein to put in a line. When this could be again prevented. But facial cellulitis does happen if it's by the eye and cause the eye to go shut, and then it also can spread to the brain area. And then if it's on the lower jaw, you are risking the chance of the child having difficulty breathing. So once we see severe swelling of this nature, you want to make sure that you get it under control so the child can avoid hospitalization. A lot of times parents don't want to get x-rays, but we recommend x-rays very early. X-rays help us to detect decay that we can't see with the naked eye. So as soon as the child is able to cooperate and their teeth are touching, we do recommend x-rays. They also show us in the second slide, you can see the molar on the very far right doesn't have a tooth bud. So that lets us know that even though you think it's just a baby tooth, that's the tooth that that person's going to have for life, because there's no adult tooth that's coming up or succeeding that baby tooth. So sometimes people are like, yeah, it's just a baby tooth. And then sometimes you don't have a tooth to follow that tooth. One thing that's important that I emphasize with parents is really having a routine, as opposed to letting your child run the show. But routines, children appreciate routines, they appreciate schedules, they, and then incorporating brushing and flossing. Once you start to do that, it becomes second nature. And if you start those habits early, you wouldn't have to be screaming at your child, because they'll know it's come home, eat, bath time, brush teeth, floss, bedtime, read story, go to sleep. But again, if you do certain routines, like every night, we start watching TV and then we just fall asleep, we don't put on our pajamas, we don't get into bed, we don't read or whatever, that's what they're going to be used to. So to break those habits are going to be a problem. So it's important to establish good habits, and children appreciate it. They also appreciate it in the form of charts. So I encourage parents to make charts. And again, like Doc was talking about before me, children respond better to positive reinforcement rather than negative reinforcement. So telling your children what to do all the time, do this, do that. If you don't do this, I'm gonna do this to you. They don't really respond that well. But if you're praising them, if you're saying, if you do this, this ends up, like she said, you're going to be healthy, you're going to be strong, you're going to be smart. If you accomplish everything that we put on the chart at the end of this week, it's going to be a treat, whatever that treat is, they tend to be a little bit more motivated to follow directions and schedule. Another thing is ensuring that your child has the proper hygiene tools. So choosing the right toothbrush and toothpaste. I've seen a lot of parents asking me about those automatic toothbrushes. I think they look like a tray and it goes back and forth and it's easy. We always choose the things that are easiest, and the things that are easiest are always the worst. So you want to make sure that your child has an appropriate size, child size, soft bristle for adults and children. Nobody should use medium or hard. Toothbrush, and we recommend fluoride toothpaste from the time that they turn 1. And it doesn't matter if they can spit or not, but what matters is the size. So if they can't spit, it'll be a rice grain size of toothpaste. And if they can spit, you can do a pea-sized amount of toothpaste. You can also start to incorporate flossers, floss, water picks, fluoride rinses, and mouthwashes, depending on the age. So always check the bottles or ask your dentist. So this is a diagram of rice grain, which is a smear, and that's all you need. And then a pea-sized amount. So as you can see, like the colors are on the toothbrush, and that indicates like a roughly about the area that you would put the toothpaste. And then again, you would only use a rice grain amount if they can't spit, and you can just wipe their teeth afterwards. And then you can use a pea-sized amount from being able to spit and older. Tips for brushing: try to get your kids to brush in a step-by-step guide. So don't just let them willy-nilly kind of brush back and forth. Try to go in a sequence each time, and also 2 minutes 2 times a day. So you can buy a timer. A lot of the toothbrushes have like a little song on it. So you get them used to the fact that they need to take time, because kids will say they brush, but when you go back and you check, they didn't really do a good job. Kids are actually supposed to have supervised brushing until they can either tie their shoelaces by themselves or write in cursive. So usually that is when they have the manual dexterity to be able to brush their teeth on their own. You want to make sure the toothbrush is on their gums and their teeth. And so if you see the gums bleeding, don't think that you brush too hard. I hear that all the time. I'm brushing too hard because I see blood. That's not why. It's because your child has gingivitis, because you weren't brushing. And so the plaque disruption is causing the gums to bleed. Anytime you use a soft bristle toothbrush and you brush gums, their gums should not be bleeding. And when you floss, your gums should not be bleeding. If your gums are bleeding, it's telling you that it's time to get a cleaning, or you haven't been taking care of that area very well. And so there's inflammation. So this is just a diagram that shows you how you really should be brushing, and you should, again, start like in a motion, always go like, if you're going to go from top right, go from top right to top left to bottom right, instead of willy-nilly, so that you treat each tooth as its own personal cleaning. Again, like Dr. Demerit was talking about, make brushing fun, as with eating, as with anything with kids, try to make it fun, because that's how they're motivated. Use colorful toothbrushes, toothpaste, find something that plays their favorite music. YouTube has wonderful videos that sing along with brushing. They have special characters that they like, that they emulate. So you want to, again, incorporate that into the brushing routine. And even when they're just like on their tablets, it's good to watch things that you want your kids to emulate in terms of like good habits. So this is just an example. We just got this toothpaste in the office. And so the toothpaste is blue when you first put it on your teeth, and it changes to pink once the 2 minutes is up. So you kind of let your child know, hey, if the toothpaste isn't pink, you're not done brushing. So cute things like that are what kind of motivates kids to brush. And then again, this is like a sample brush chart. You let them tick off morning, afternoon. And then at the end of the month, you say, okay, you did this. So you get like a little yogurt treat or ice cream. Ice cream is fine, but not like a bunch of candy. Another thing, again, same repetitive thing, setting a good example. You can't expect your kids to do things that you don't like to do. So you can't expect to have all this junk and stuff in the house that you like to eat because you like Flamin' Hot Cheetos, and then expect your child not to want to eat Flamin' Hot Cheetos, or you like candy and gum and chips and cookies and soda and juice. And then you say, well, I try to put it up, but then they find it. And I'm like, who's buying it? You know, the kids are not going to the store and buying it themselves. So you have to be aware of what you have in the house and what you go and pick up. And so we encourage parents and caregivers to set examples, not just about brushing and their oral hygiene, but also about, like, again, the diet. If you don't brush your teeth at night and you don't have a nighttime brushing routine and you don't floss, you can't expect your kids to floss and brush at nighttime either. And if you don't like the dentist and you talk about how much you hate the dentist, you can't expect your child to come to the dentist and behave like an angel. So again, you can do brushing in the mirror. Kids love to emulate their parents. But you can do brushing at nighttime in the mirror. Obviously in the morning time when they're getting ready for school, it's kind of hard, but nighttime is a good time. Also, you don't have to always take time out to brush in the mirror. You can also brush their teeth in the bathtub whilst they're kill two birds with one stone, you know, so that they're ready, taking their afternoon bath and brush their teeth and whatnot. Again, she talked about this earlier, Doc talked about it earlier. Avoiding juices and sodas. We're drinking water. Water helps with overall health. Water helps to rinse away food and bacteria. You know, your kids shouldn't have more than a 4-ounce juice box a day. And as I wrote down a note when she talked about it, if you're only supposed to have 25 grams of sugar per day, most juice boxes or juices have 25 grams of sugar. And that's just the juice. That don't include anything else that you're giving them. And again, reading the labels, like she said, because you thinking that you're giving chips or something and it's not sweet, but it still has sugars in it. So you do have to pay attention to all foods and how much sugars they have in it. And also, once you start introducing kids to juice and sugary beverages, to get them to drink water is salacious. So, you know, we try to recommend little drops, sometimes flavored water for those kids who are already addicted to sweet drinks, to try to get them back on the track of drinking water. But again, once you start it, it's very hard, you know, to get them to give it up. We really beat the sugary snacks to death, but I'm going to go over it a little bit more. In terms of snacking, you want to avoid foods that are sticky, that when you finish eating it, you still see it on your teeth. So gummy vitamins, like we were talking about earlier, are horrible. They do contain sugar and they're sticky. So they are just like eating little candies. So I don't recommend gummy vitamins as a supplement. And also I hate fruit snacks. They're not fruit, they're candy. And so people always put little Welch's fruit snacks or Mott's fruit snacks in the bag like a little treat, and they are hellacious on the teeth, as well as things like goldfish. So like when you finish eating goldfish, those are not sweet, but those are sticky. And when you finish eating it, there are carbohydrates. Carbohydrates turn into sugar. Bacteria feeds on sugar and produces acid, and that's how you get a cavity. So you don't just get a cavity from sugar being on your teeth. It has to be, the bacteria in your mouth has to have something to feed on, and that can be chips, cookies, beverages, whatever. And then the acid spews out, and that's how you get a cavity. So overall, you want to avoid sticky, chewy stuff, and you want to focus on whole foods that are very slippery, crunchy. So apples, yogurts, and things of dairy, all that is very good in terms of diets that you want to consider that are good for your kids. So we were talking about tooth-friendly snacks, cheese, vegetables, fruits, cheeses, yogurts, and I agree with Dr. Demerit in terms of hiding veggies in certain things, and also just being creative. There's so many ways that you can figure out healthy lunches. This is not like back in the day. You can go on YouTube, you can go on Pinterest, you can go on Google. They have like so many ways that you can flip lunches and figure out how to make lunches healthy. So there are endless recipes. There are even Instagram people that focus just on getting toddlers to eat healthy food. So there's really, at this point in 2023, no reason to just be negligent on getting your child like healthy foods. These are examples of the unhealthy foods. And the last part I'm going to go into is just about like kids and sports and dental trauma, the aspects of dentistry when it comes to your older kids and going to school. So a lot of us are like, have our kids in baseball and what else? Basketball, and we don't wear mouth guards. We're like kind of like, what's the point of a mouth guard? But mouth guards really help to protect, especially when the child has a mixed dentition, which means they have permanent teeth and baby teeth. And you want to make sure that you protect those permanent teeth. And these kids tend to play very rough, and they should always be wearing a mouth guard. Some people do get the ones that are over the counter that are called boil and bite, but ultimately the best mouth guards are custom mouth guards that you can have made at your dentist. Make sure that the mouth guard, regardless of if you get it as a boil and bite or one of the ones that you might purchase off of Amazon or Walgreens or whatever, that it fits the child's mouth. And then the other thing I want to talk about, I'm going to go to the slide. That's the mouth guards, is just at the bottom, right? You'll see the top teeth look pretty clean. That's after we remove something called swimmer stain. So a lot of kids swim, and when they get in the pool, if the alkalinity of the pool is not right, or they don't have the right mix of chemicals, you can get what we call swimmer stains. We do get a lot of kids that do swimming as a hobby, and they get this buildup of this weird stain on their teeth that we tend to have to bring them in a little bit more often for cleanings. And we get that a lot with swimmers. So we encourage them to try to brush or rinse their mouth when they come out of the pool. And then the slide that's closer to your right side shows severe overjet, which we'll call like buck teeth is the common term. And those teeth, people say, okay, well, I don't want to get braces because the child is so young. But what that does in correcting it early is if they play sports, these teeth that are kicked out very far tend to be easily prone to getting damaged. And so if you damage a permanent teeth, the amount of money that you would spend in either an implant in the future or a root canal or whatever is way more in terms of braces over a period of time. So these types of kids, even though they might be 8 years old or 7 years old, we tend to refer them to the orthodontist early. So this is just an example of some dental trauma. Typical things that we always see is chipped teeth from either playing on the playground or playing rough at school. That would just require just like a filling, that first slide. But then we have more severe cases where maybe the child at the school hit completely avulsed or the whole tooth came out. And that's what you see in the middle slide. So you want to encourage your school nurses to keep milk on hand. They can also order a saline tooth solution, which you would want to put the tooth in, but you want to try to find the tooth on the playground or wherever it is at home or wherever on the softball field, put it in cold milk and try to find the doctor as soon as possible, because what makes the difference in the tooth being saved is the timing that you place the tooth back in the mouth. So the last slide with the splint shows that we put that same tooth back. That's the same patient. They came in with a tooth and we put the tooth back in probably less than an hour, which is better than in determining the success rate of the adult tooth being saved. If it's a baby tooth, we don't recommend implanting those. So if you have a child that knocked out their baby tooth and you see the whole tooth, we don't implant those. So some of the services that are offered, we talked about already, but when it does get to those cases that we have all of those complications that are preventative, we do have to figure out how are we going to treat these kids. And so we have, this is another 4-year-old, again, all the teeth are decayed in the upper arch and we had to replace those with crowns. He wasn't going to lose those teeth for another, actually he might have been like about 3 years old. So another 3 to 4 years. And so this particular patient we put under general anesthesia to fix all of the teeth. We don't typically put kids under general anesthesia unless it's a significant amount of work. And that usually is 8 or more teeth needing to be restored. And if the parents know that there's going to be a behavior issue or it's going to really like be a hard few appointments. On a typical day, we use laughing gas that helps to relax kids. And basically, overall, as a pediatric dentist, our goal is to make sure that the kids are not traumatized. Like you should not have your kid go to the dentist and say it was horrible. They were crying, they were screaming. It wasn't that bad, but they cried. You know, the goal is that the experience was a positive one, or they didn't know that they got a needle. They did not know that when the tooth was pulled and this, that, and the other. This is another, like, I think he's like 2 years old, again, 2 years old from the bottle. Things that, again, could be prevented. And that is the end of my presentation.
What a wonderful presentation by both presenters. Thank you, Dr. Darville, and thank you, Dr. Demerit. And we are welcoming questions. I'm encouraging everyone to put your questions. You can place them right in the chat. Hi, can you hear me? I was talking, but my mic was muted. Thank you, Dr. Darville and Dr. Demerit, for such an awesome presentation. And we do have questions, so I'm encouraging everyone, you can post your questions in the chat, and we will go ahead and ask. We do have a few questions that are popping in. And the first one I'm seeing is, can almond milk substitute for whole milk? I think this may be a question for Dr. Demerit.
Okay, yes. So I mentioned that earlier. So ideally, whole milk has the recommended vitamin D and calcium that a child will. We do have patients that have cow milk. They have allergies to regular whole milk. So the plant-based milk can be used as a substitute, but keep in mind it does not have as much vitamin D and calcium that the regular whole milk have. So they can use it, but I will also still speak to your pediatrician to determine at that time your pediatrician will go over the entire nutrition history to make sure that they are getting the appropriate amount of calcium and vitamin D that's required.
Okay, and Dr. Demerit, there's another question that is related. They're asking if the age of 1 is too early to give almond milk as a substitute.
Okay, so So the formula, your regular baby milk formula is recommended from 0 to 12 months. At 12 months now, we can now transition to whole milk. Pediatrician to make sure you're getting recommended the daily recommendations for your vitamin D and your calcium, which may not necessarily that amount that's in the whole milk may not be in the oat.
Okay, now Dr. Demerit, I'm not sure. I think there may have been some interference.
I use it.
Yes, it was kind of
Okay.
cutting in and out. So I missed part of your response.
Right. So the question was about, or so Ms. Dana, you can hear me.
Yes.
So what I had mentioned was that we have well, okay, so ideally breast milk for the first 6 months of life. Let me start here. There are some parents though where we have to use formulas from 0 to 12 months. Once a child is 1 year old, we can now transition to whole milk. Okay, that's the recommendation. If for some reason your child has milk allergy or allergic to the regular milk itself, then you can use the plant-based milk. Soy is most similar with regards to the vitamin D and calcium that's in the whole milk.
Okay.
So they can use it. They still to their pediatrician. Their pediatrician will go over the entire nutrition history, the part of the well visit, and will then determine if additional vitamin D and calcium supplementation is needed. But the recommendation really is to transition to the whole milk.
Okay, thank you for that response. We do have more questions. So there's one question that's coming in for Dr. Darville. And the question is regarding children who grind their teeth, in their sleep. What's the advice or what kind of recommendation, or maybe either of you, I don't know, can kind of chime in and give us some insight into that. I see both of you are smiling. What is that?
Yeah.
Yes, well, the first thing.
I'll let Dr. Darville answer that.
The first thing, the official term is called bruxism, and I like to let parents know that so that way they can do their own research.
Yes.
But bruxing is very normal. It's a part of growing up. It's a part of transitioning through their dentition. Sometimes in recent years, we really have been paying attention to whether or not is associated with snoring or difficulty breathing. So we'd kind of like look into whether or not they have any sleep issues. And at that point, I would kind of reach out to the pediatrician and see if there's any issues with tonsils and adenoids or sleep apnea. Most of the time, that is not the case. And it's typical, just a normal part of growing up, even if it sounds like and it's not worms. That's usually the take-home message that we usually try to let people know. It's not worms. Sometimes the kids are anxious and they are very worked up, and it's a way that they kind of relieve stress in their sleep is by grinding. And so people are like, why would my child be stressed? But they tend to have different stressful events in the day. And so, yeah, just in general, it is pretty normal. So we don't get too worked up about it unless, like I see, there have been a few cases where we had to recommend tonsils and adenoids being removed, and it did kind of help with the bruxing. But for the most part, that isn't a typical situation.
Okay.
I'll kind of chime in as well.
Yeah. Dr. Demerit, do you have anything to add?
No, that's pretty much the recommendation. I do find though is that there's some kids who have like, stressful schedules, parents of them doing a lot. They have to go to school, they have to go to swimming, they have to go to dancing, then they go home at night, they have to do the homework. So at night they it's just a stressful day, the parent being on a plateau. But for the most part, we don't find any other abnormality really.
And just to add to that as well, a lot of parents don't really take advice when it comes to the stresses that their kids are under. So other things that manifest are sometimes we get a lot of kids with canker sores, and those are related to stressful events. Like if they're taking exams, they may get like a lot of little mouth ulcers or something like that. And so a lot of times a recommendation for kids that I find that a lot of Bahamians don't want to do is seeking therapies for their kids, because a lot of kids have a lot of underlying anxiety, and we don't really take anxiety in kids seriously, but they do have anxieties that present in a lot of their behaviors, and also physically, like in the terms of bruxing or an ulcer or something of that nature.
Okay, Dr. Dawa, this is a question for you as well. Demetria is saying that she wasn't able to quite follow what you were saying regarding electric toothbrushes. And so she's asking if they're good for kids.
Okay, I didn't really clarify that. Electric toothbrushes are fine. Powered brushes are fine, but that is not to be mistaken with these new trend automatic toothbrushes, which are like kind of like a bite tray that you see that kind of just you press a button or it goes back and forth. Those are not, or you put it in your mouth and you just press a button and it's supposed to brush your teeth for you. Either way, whether or not you're using a manual toothbrush or an automatic, or sorry, not an automatic, but a powered toothbrush or a battery operated toothbrush, you still have to show your child the technique, because I have parents who say, well, we have a battery operated toothbrush and it's just like they didn't use anything. They might as well have just used water in their finger, because you have to still put the toothbrush where it needs to go and allow it to manually still, brush each area and brush the gums. So I don't like to recommend them early because it makes the kids lazy. But if it's a situation where the kid is really like attracted to the toothbrush because it has a sound or it has their special character on it, then I'll be like, okay, we'll just still go behind and see, if they left any plaque behind.
Right. And just to follow up to that as well, because I know you mentioned that the age of 1 is when, they should really come in for their first visit. So Smith is asking for a latecomer, and they're calling 2 to 3 who've never visited a pediatric dentist. How do you prepare them for that first visit?
You can hype them up. You can let them watch, like every single show I know has a visit to the dentist. Peppa Pig, Paw Patrol, Bubble Guppies, Gracie's Corner has a song about it. Everybody has a song about it. So usually those are great, especially whoever they're excited about. Books are good to read, like your first visit to the dentist. And then, just hyping them up. It's going to be fun. The dentist is going to look in your mouth and kind of show them like, what you don't want to do is what people do. If you don't behave, I'm going to tell the dentist to give you a needle.
Yes.
Or when you go to the dentist, guess what they're going to do? They're going to pull your tooth,
Yeah, that too.
So, a lot of people, and then something that a lot of people do that I don't understand is they let their kids sit in on dental visits that they had, like with their adult dentist, and they'll let them sit in the corner, and then they'll come and they'll be like, well, she just saw me get my tooth pulled last week, so she's scared. I'm like, duh.
I wonder why.
So, so those kinds of things, just keeping it positive and pleasant. And, if you do want to do a reward system, not a bribe, but a reward system that, do well at the dentist, we'll go here or we'll do this, then, that's also going to help.
Okay. Thank you.
Yeah, I think the reward system should be, we need to change the culture. So instead of rewarding with candy or food, maybe with some activity,
right?
Park,
Yes,
so
I agree. Yeah, I agree.
Like to that,
I agree wholeheartedly.
Yes. Okay, and this may be a question for both of you. At what age would you not consider
a child to be a pediatric patient anymore. And that's for both of you, where they can transition to an adult primary care physician and an adult dentist.
Okay, I'll go first. So actually, to be honest with you, pediatrics can actually go up to age 21. Even though we some pediatricians, depending on what's going on, may stop at the age of 18 and start to transition them to what's get them ready and say, okay, you have to start thinking of going to an adult doctor now. So for me, it's a case by basis, but for the most part, most pediatricians go up to age 21.
Age 21, okay. Dr. Darvel?
Mine is a little different.
I would say 18 to 21.
What I would say in the beginning of my practice, I probably was taking 0 to 18, but I will say that at this point, with more parents becoming educated, I have to focus a lot on the really, really young kids, and we have a lot of kids on the spectrum. So my schedule is filled with kids pretty much 8 and under that I typically see, and that's because I do a lot of sedation and behavior management is
okay.
I focus on. So once I see the kid, or the child, I should say, can handle seeing a general dentist who can manage children. I have an associate, she's a general dentist, but she's, trained to work with kids. If I see that they have the mental capacity to handle somebody who isn't going to necessarily have to do the same behavior management techniques as me, then I'll transition them. But I also have teenage patients who are just like 2-year-olds when it comes to how fearful they are. So I still have to see them. So it doesn't really have an age. It's just really a maturity level that I make a decision. And then I also have kids that are off in college that love coming to my first dentist. They still want stickers when they come from boarding school or college, and I allow them to stay. But we try to kind of strike a balance because we don't want to fill the schedule up with kids that can see other people, and then we're kind of like lacking appointments for people that really need the specialist.
Right. Okay. Thank you both. Shawnique Ferguson is asking Dr. Darvel, what can you give or what can you do to allow a 3-year-old to prevent a 3-year-old from sucking their thumb? And she's saying, bear in mind, the child's thumb was in the mouth from the womb, and she saw this on the ultrasound scan. So she wants to know, I guess either of you, maybe Dr. Demerit can also chime in here. How does she stop this behavior?
Well, there's really nothing you can do. I'm not even gonna lie.
Well,
I will say that you can try. I'm gonna let Dr. Demerit start, and then I'll finish with what we kind of recommend.
No, 3 is not age 2. That's kind of difficult. Because even if I'll let you speak with regards to the thumb sucking device. I'm not sure if you do that, but it has to be at an age where they can kind of understand what's going on. And so 3 is not a good age to I want to say do something drastically try to prevent them from sucking their finger. You don't want to do it because is there a way of comforting, soothing, dealing with certain things?
Coping mechanism.
Yeah, that's a coping mechanism. So 3 is not a good age. Unfortunately, I guess not unfortunate, but it's not a good age to try to say take it away from them because they don't understand quite that age. So they don't.
Yeah, so I would say that those kinds of habits are either you really kind of have to knock them out before they can understand. Like, so you were, taking the pacifier. I know pacifier and thumb sucking is not the same, but if you're going to take pacifier, you got to do it before 3, but once it becomes a coping mechanism or a stress reliever, it's kind of hard. If they have been sucking since the womb, we can put pepper, you can do it. We do recommend a thumb guard. That sometimes works. It depends on how dependent on the thumb the child is. So usually I'll ask, how often are they doing it? Are they only doing it to go to sleep, or are they doing it constantly? Like from the time they wake up to the sofa, to the school, to the classroom, or whatever. Those types of consistent all day habits are very hard to break. But we do tend to recommend something called a thumb guard. That works. That's a hit or miss. So that's why I said in the beginning, it's kind of like hit or miss, but a lot of it with children has to do with their own psyche. Are they ready to stop a habit on their own? I'm not talking about the bottle, but I'm talking about like if they bite their nails, or they have they like thumb sucking. So most of the time, again, positive reinforcement tends to work better. So parents come in and they ask me to put a habit appliance in, which is like a retainer with a guard that pokes their finger. And a lot of them, especially boys are very defiant. They just pull it off. And so the parents are like, I thought you cemented it, and they just yank it off. And there's nothing we can do. But it tends to work better when I ask the child, are you ready to stop? And they'll actually tell me, yes, Dr. Darvel, I'm trying, but every time I try to go to sleep, it's hard for me to not put my finger in their mouth. And those kids are the ones that the appliances work best on. And that's in all kinds of studies. So that's not just me making that up. But if you do want to try and you think that the habit's not so excessive, you can try something called a thumb guard. But again, it has to be consistent. You can't put the thumb guard on at one night, and then don't put it on the next night or whatever, because then the child is going to have a bunch of relapse and it's going to be pointless.
Okay, thank you both. We have 2 questions, and these will be our 2 final questions. Dr. Darvel, what age is appropriate for a child to get braces?
Again, everything is independently related. There's no hard, fast rule. There are kids that I've sent for braces at 7 because they've really needed it. And in the cases that I was talking about with Overjet, there are some situations that are jaw related. So the recommendation is that they have their first orthodontic consult by age 7. So the pediatric dentist, myself, is trained to be able to figure out what skeletal or dental problems need to have a referral early. But I've referred kids as young as 7 for orthodontics. And then there are cases where it's for cosmetics only, or it's something that is not going to hurt the child to wait until their teenage years. So if somebody tells you wait until all the baby teeth fall out, they're sadly miseducated. Because it just depends on your child and growth and development. And there are a lot of times when kids should have been referred early, and because they waited too late, that's why they're wearing braces for like 6 years or something ridiculous, or they have to get surgery or this thing and the other thing.
Right. Okay, thank you, Dr. Darvel and Dr. Demerit. This is our final question for you. What do you recommend for kids who sleep with a sippy cup of milk and cereal to get to sleep? And this is to I know we touched on this, we hit on this earlier because it damages but this is a parent, I guess they're asking because they want to know how do they break this habit?
Yeah, that is totally not recommended. Even from general peace, definitely on Dr. Doc, I totally recommend to let the child go to sleep with a cup of milk and cereal. How old was the child again? I'm sorry, I didn't get that.
Well, they didn't give an age. No, they didn't give it. Smith, if you're still there, can you give us the age of the child?
She is just going to start at nighttime. During the day. So that's a question. That is something the pediatrician will have to be able to guide us through. We'll have to choose certain things during the day, certain routines that nighttime that's not recommended.
Okay, so the response is 2 going on 3, age 2 going on 3 years old.
No, the child should not be still drinking a sippy cup of milk and cereal at age 23. Not at nighttime,
So
not at
sippy
no time. But
Yeah, we pretty much guide the parents from 14 to 16 months. They should be off a bottle, and that includes sippy cups with nipples,
yeah,
anything like that. So around 14 to 16 months, you really should be getting rid of those things. Now, if you transition your child into a sippy cup and then you put formula in it, or formula with rice cereal, which is even worse, you're just gonna have to treat it again like a habit that you have to break, and you can kind of try to figure
break.
out
Yeah,
if you're gonna do a slow weaning or if you're gonna do a cry it out. Either way, you're gonna have to figure out if you want to do a cry it out. Sometimes kids that age are mature enough to know, let's go and put sippy cup in the garbage. No more sippy cup. You're a big girl now, and then you give them a special cup that replaces it. You can give them warm milk before bed if you're gonna like brush teeth afterwards, but you're gonna have to figure out how to try to create a positive new routine. And the first step is
yeah,
just gonna start with a decision that you're going to make, that you're going to do it. And if they do cry, you're okay with the fact that this crying is not going to last forever. Because I have 5-year-olds and 6-year-olds who still want to be on bottles. So it's not a situation where kids just be like, oh, I'm just not going to do it anymore. It's going to be the parent having to make a conscious effort of how we're going to break this habit, whether we start with something positive or like some kind of supplement. And don't switch it to like now again a Milo or Ovaltine or something, or a Pediasure.
Ovaltine,
You
please.
can kind of like, say you can have your hot cocoa with your dinner in your special cup. And then after that, we're just going to have water in your special cup when you go to bed.
Yeah. So by age 15, like Dr. Dava said, 15 to 18 months, we should be weaning them off. And by age 2, they should be off that completely. So that's something that you would have to sit down, work through with a pediatrician to try to come up with a plan to get her off of that.
Yeah, yes. Now, Dr. Demerit and Dr. Dabble, I will tell you that you are kind of crushing a lot of hearts because you know a lot of people, especially those island folks. No, that Ovaltine in the cup, that sippy cup or in the bottle, that is in the juice. Dr. Demerit talked about the juice earlier. They have that juice right after they introduce the solid foods, the baby food. So, but this presentation has been very informative. And I can tell you there are some comments also in the chat. They said, thank you both. Your assignments were executed clearly. Continue the exemplary services. And earlier that I saw that, and that was from Shawnique Ferguson, Crooked Island. And then we had another comment earlier. They said it was an excellent presentation. And so, our audience is very much pleased for the information that was presented today. And it's timely because it's now back to school. And so now they have, kind of guidance as to what needs to happen nutritionally and for the dentition of their children moving forward. Me too, for mine as well, my children as well. So I want to say thank you both, but I would also invite our the Vice President of Bahama Health, Mrs. Charlene Rogers, and she will also bring closing remarks.
Good evening. Nurse, can't believe we're doing just an excellent job. But really, I want to say thanks to Doctors Davil Gardner and Knowles Demerit. Really an excellent presentation, and it forms healthy habits. I like the tips and the reinforcement you've been able to give to parents, and then I guess others who are online, how we can really form strong habits for our children. I also like your care provision in that, when we start at that pediatric age, we can advance on to that adult age. So it's really a continuum of relationships. And so I would encourage parents who have not established one, please ensure you get in touch with that pediatric dentist and your pediatrician. It really pays a wholesome life, I guess, wholesome lifestyle. They're there to support you, give you the guidance. And it's amazing to what our children pick up when they go to the doctor's office. So I think the behavioral management, that is excellent. So there's indeed a lot. There's a wealth of information you would have shared. I also want to thank the team from Bahama Health that put on these series every month, all the follow-up and reaching out to our policyholders. As you know, too, we do a recording of this, so it will be shared further far. And it is our hope that for the audience here, as well as others who will hear, they will also reach out to you. Your contacts will be shared on the presentation. So we say, just don't run away. Make sure you get the addresses. But again, thank you very much. This has been timely for back to school, and I'm sure everyone who attended the session has left with some nugget this evening. So again, many, many thanks for partnering with us.
Well,
Thank you too. Thank you so much. Thanks to everybody.